is temporary. It may last a minute, or an hour, or a day, or a year, but eventually it will subside and something else will take its place. If I quit, however, it lasts forever. That surrender, even the smallest act of giving up, stays with me. Welcome back to another episode of Oncology for the Inquisitive Mind. Michael, knowing how inquisitive you are, do you know who said that quote?
Honestly, Josh, my first instinct was that it was Rocky Balboa, and I was expecting you to do your best Sylvester Stallone impression, which is not fit for broadcast, but I suspect I'm wrong.
You are very much incorrect.
Rats.
That's all right. That was Lance Edward Armstrong, the American former professional road racing cyclist who won the Tour de Force, and there were some controversies, but ultimately I should have very much used this quote when we did our testicular mini-series. And if you haven't checked that out, it's a couple of episodes ago and it's great. But this week, we're going to continue our Tour de Force of neuroendocrine tumours. That was a specific request from a loyal fan about using that quote. But Michael, do you want to give us the background?
Josh, I will say that you said Lance Armstrong won the Tour de Force.
Well, Tour de France. Oh my God. And we're not going to edit that, I'm sure. So Lance Armstrong did win the Tour de France, and this is our Tour de Force of neuroendocrine tumours. Michael, thank you for correcting me. But do you want to start this episode before I shrink further from the microphone?
Yes. I think that's probably a good idea. Let's get this back on track. We've gone through advanced, well-differentiated, low-grade neuroendocrine tumours, and not to spoil anything, but our next and final episode in this series will be focusing on neuroendocrine carcinomas, which are a very different entity. However, there is a in-between point. There is a type of neuroendocrine tumour that is too high grade for a intermediate grade neuroendocrine tumor classification, but not aggressive enough, not small cell enough to be called a neuroendocrine carcinoma. And so this episode will have a particular focus on the entity of well-differentiated grade 3 neuroendocrine tumors. This is a fairly new entity, and you can sort of tell that it was a bit of a plugging of a hole in the original 2010 WHO classification. So it only was inaugurated, shall we say, in the updated classifications published in 2017. And it was specifically created to account for tumours with a well-differentiated morphology and a Ki-67 of greater than 20% and or a mitotic index of greater than 20 mitoses per 10 high-powered fields. For reference, a low-grade neuroendocrine tumour has a Ki-67 of less than 3%, and a intermediate grade has a Ki-67 of 3 to 20%, so grade 1 and grade 2 respectively. So grade 3 neuroendocrine tumours account for approximately 20% of all NETs. They're most commonly found in the pancreas, the colon and the rectum, and the stomach. There's a scarcity of data about these tumours, which is a refrain that you'll hear repeated multiple times in this episode. But depending on the source, the frequency of grade 3 neuroendocrine tumours arising from the pancreas is between 10 and 65% of all neuroendocrine tumours arising from that region.
Michael, do you find that just a huge reference range, 10 to 65%?
Well, as our listeners will soon realise, we are talking about series that will have 10, 20, 30 patients. So that is between, for example, 1 to 6 patients out of 10. It's a very wide reference range, but it is also taken from data sets that are very small.
And it's a very rare cancer.
It is. It's a rare subtype of a rare cancer. But there is the potential that the more we look at neuroendocrine tumours and the more are diagnosed, the more experience we have, that the rate of these grade 3 neuroendocrine tumours will increase. In terms of colon and rectal grade 3 NETs, these account for between 8 to 25% and a similar incidence with grade 3 NETs arising from the stomach. between 5 and 50% of grade 3 NETs are functional tumours. And if we're trying to draw areas of differentiation between grade 3 NETs and the similar but at the same time very different neuroendocrine carcinomas, 0 to 6% of neuroendocrine carcinomas, or NECs, are functional. So if you have a functional tumour, aka a tumour that lights up on functional imaging such as dotatate or GAT8 PET scans, symptoms consistent with carcinoid syndrome, it is much more likely to be a grade 3 neuroendocrine tumour as opposed to a neuroendocrine carcinoma. In terms of tumour markers, there are several that are used in common clinical practice. We've mentioned chromogranin A, which is a terrible, terrible marker for diagnosis, but is a good marker for monitoring response to treatment, as well as the transformation from a neuroendocrine tumour to a neuroendocrine carcinoma, which is something that we do see. There is also the neuron-specific elastase, or NSE, which I've seen mainly in trials. I haven't seen it used clinically. Josh, I don't know if you've seen NSE used as a diagnostic tool.
From my clinical experience, I've never seen it used, Michael. We used a fair bit of chromogranin A to assess response, just like you said so eloquently and wisely. Michael is the wisest amongst us. But no, I have not used this.
Yeah, it might be something that is coming in the future, but a lot of labs might not be set up to actually examine for the NSE. The other marker that's used is 5-HIAA, or urinary 5-HIAA, which is generally used as a marker for midgut functional tumours. And so if you have a non-functioning tumour, the 5-HIAA is unlikely to be significant. One study found elevated chromogranin A was present in 42% of cases, NSE elevated in 25% of cases, and 5-HIAA in 25% of cases as well. However, this study only had 12 patients in total, and this is emblematic of the problem, Josh, that we have these percentages, but they're kind of pointless when you're only dealing with a population of 12 patients.
That's it. It's just so difficult to make any assessment with such a small, diverse, heterogeneous group of cancers.
Yeah, absolutely. As mentioned before, most grade 3 NETs do overexpress somatostatin receptors on SRI, or somatostatin receptor imaging. That's your dotatate and your GAT8 PETs. And there is an inverse correlation between Ki67 and the maximum standard uptake values, or SUV max, on these imaging modalities. Again, another small series, 25% of grade 3 NETs had FDG avid components, which means that in common parlance, FDG PETs are used to differentiate and investigate when a lower grade neuroendocrine tumour might be developing into a more aggressive neuroendocrine carcinoma. However, because a small but significant proportion of grade 3 NETs have FDG avidity at a baseline, the utility of this, what we call FDG discordant disease, might be slightly less compared to lower grade neuroendocrine tumours, which are typically mostly negative on FDG PETs. It's also important to note that grade 3 neuroendocrine tumours, with their Ki67 values, with their mitotic indexes, they are a range. And the higher the Ki67, in general, the more aggressive the cancer is going to behave. But it does show the heterogeneity, which Josh mentioned before, of this tumour group. However, if we're going to draw a direct comparison to grade 3 NETs compared to neuroendocrine carcinomas, they generally carry a much better prognosis. And some studies, again, small series, we keep on saying it, but some studies suggest that the prognosis of grade 3 NETs is similar to intermediate grade 2 NETs. One study demonstrated a survival ranging from 41 to 99 months compared to 5.3 to 17 months with neuroendocrine carcinomas. However, the higher grade of a grade 3 NET compared to grade 1 and grade 2 also carries a higher risk of metastases at diagnosis, which is a major risk factor and a major impact on overall prognosis. The data on treatment, stop me if you've heard this before, Josh, but the data on treatment of grade 3 NETs is scarce. What a surprise. The use of somatostatin analogues is generally recommended to be done with caution and close monitoring because the evidence is not there. The seminal studies, which include the clarinet study, which we spoke about a couple of episodes ago.
And Michael, don't forget you played the clarinet a lot during high school.
Oh, you just had to bring that up, didn't you? Never misses an opportunity, this man. But the clarinet study did not include any grade 3 nets. The classification actually didn't exist at the time of the study being published. So if you do have a grade 3 net, the general recommendations are to use agents such as lanreotide, other somatostatin analogues with caution and close monitoring, because the efficacy is unknown. It might not be significant. Although, Josh, it would stand to reason that if you have a somatostatin receptor expressing tumour, then blocking that tumour would produce some therapeutic effect.
You would think so, because when you've got a receptor and you stop it, theoretically it should have a response, but maybe there's multiple mechanisms we're unaware of, and thus it's a bit of a superfluous, like inhibiting, I don't know, AKT or inhibiting, an EGFR, and it becomes resistant.
PIK3 kinase, that sort of thing.
Yeah, exactly.
The other agents that we've discussed already in this series were everolimus and sunitinib, and there is some evidence that these agents will have some effect. There is a phase 2 study of everolimus in this population called EVINEC, but this study is ongoing and we don't yet have the results. So we will await that with great excitement. The other thing that is frequently brought up in the treatment of these grade 3 neuroendocrine tumours is platinum-based chemotherapy. The rationale for this comes from the extrapolation of the standard treatment for neuroendocrine carcinomas, so moving away from grouping them with the neuroendocrine tumours and more towards the neuroendocrine carcinomas. But again, it makes it tricky to extrapolate any data from other sites because this is very much a spectrum of disease. What little evidence there is that platinum chemotherapy really doesn't work in this population. Again, we're dealing with several small series, but they consistently demonstrate a less than 5% response rate for platinum-based chemotherapy in grade 3 NET. There are 3 series that I looked at in preparation for this episode. One published by Velaidum Sefis et al. In 2015 demonstrated a response rate of 0%, absolute zero. A series published by Heatfield et al. In 2015 demonstrated a response rate of 2%. And another series by Hijioka et al. In 2017 demonstrated a response rate, again, of 0%. There is a suggestion that more aggressive lesions respond better to platinum-based chemotherapy, probably because, in essence, they are getting towards that neuroendocrine carcinoma where Ki67 values are frequently greater than 70%. There was a subgroup of grade 3 well-differentiated pancreatic nets in the Nordic study, which demonstrated a higher response rate for patients with neuroendocrine tumours with a Ki67 of greater than 55%, specifically a response rate of 42% versus 15% in those with a Ki67 of less than 55%. Platinum-based therapy is probably not recommended in this space, but the evidence is quite flimsy, I would say, quite thin on the ground. Josh, originally this episode we were going to do 2 studies, as is our custom, speaking about platinum-based therapy and your study, which we'll get to in a moment, but because there is so little data, we figured that we would talk about the disease more and then focus on your study of capecitabine and temozolomide, which has much more promising results. It is a low bar to clear, though.
I don't actually know if there is a bar if platinum-based chemotherapy has 0 response rate.
The bar is the floor.
Yes, it is. But speaking of bars, if you like our podcast, please like and subscribe. We'd love to hear from you if you want us to talk about anything specifically. And my aim for the 100th episode, which is a little while away, is to get Michael to sing his rendition of Les Mis. But keep that in your pocket because I'm going to convince him. It might take several months, but it will happen.
It'll take at least 40 more episodes.
At least. I
must say that wasn't your best segue, Josh.
There was no segue, but let's segue back to the actual topic at hand, which is, and I guess the article we're going to talk about, which is the CAPTEM study, which is capecitabine and temozolomide in advanced neuroendocrine neoplasm, so the NENs. And it was a systematic review and pooled analysis coming from you all the way from the City of Love, Rome. Michael's already gone through most of the background.
Josh, point of order. Isn't the city of love Paris?
Well, maybe Rome is taking... I don't know what's wrong with me.
I think, ladies and gentlemen, that Josh's anti-French bias is being exposed in this episode. First, he calls the Tour de France the Tour de Force, and now he erroneously ascribes the city of love to Rome.
Look, Rome's a very romantic city. I don't know if you've been, but it's a great place to go.
We're going to have some very angry French reviews coming through fairly soon.
We will, but I love the French. Anyway, the background Michael's pretty much covered, but prognosis as a summary is that it depends on the morphology, the Ki67 reproductive marker, site of origin, and the grade. The WHO classification breaks everything down, and the management is really multidisciplinary. And there are options, which include somatostatin analogs, TKIs, the mTOR inhibitors like everolimus from our last episode, the dotatate lutetium or PRRT, and of course, the ugly duckling of the group, which is never going to become a beautiful swan, chemotherapy. All of these studies, apart from chemotherapy, have been based on randomized controlled trials. Chemotherapy prior to very recently had not. And of course, what they knew, or the background information, is that alkylating agent temozolomide showed promising activity and tolerance profile either as a single agent or in combination with capecitabine. You might remember temozolomide from glioblastoma multiforme. That's where it's predominantly used with the Stupp protocol. And of course, you've got the capecitabine, which is pretty much used throughout the oncological world: breast cancer, colorectal cancer, upper GI cancer, neuroendocrine tumor cancers. Anything else, Michael?
No, it kind of is the Meryl Streep of the oncological world. It's so multi-talented. It's used pretty much everywhere.
Yeah, it's pretty much murders in the building.
Yes, that's very topical. But if you've got a cancer, you've probably used capecitabine.
That's it. And the issue that the authors highlighted is that there is no high-quality evidence or prospective randomized phase 3 controlled trials for chemotherapy. They did a meta-analysis, and most data was retrospective. There are only 4 phase 1 to 2 studies published, and most use the gastroenteropancreatic neuroendocrine tumours. And there is some evidence to suggest a role of chemotherapy in neuroendocrine tumours and the lung and thymic origin, which are even rarer subtypes. So they did a systematic review with the primary endpoint being disease control rate, which I'll abbreviate as DCR, which is the percentage of patients who had a partial response, complete response, or stable response, with the secondary endpoints being median progression-free survival, median overall survival, grade 3, grade 4 toxicities. So they found 42 articles, 1,900 or so patients. 38 of these were retrospective. 2 articles were phase 2 studies. 2 articles were phase 1 to 2 studies, and they whittled it down to about 1818 patients.
That's one way to get over the problem of small series, is just bundle them all together and try and analyse them as a whole.
Yeah, so it's a common practice, especially in rarer cancers where you don't have a lot of robust data. So if anyone hasn't looked at a systematic review, it's quite an interesting way that they do it, and they kind of analyse everything and use very fancy mathematical things to give us an answer. The patient characteristics, so 90% of the articles or the patients were the GEP, so gastroenteropancreatic neuroendocrine tumours, and 2 studies had lung and 1 was unknown. The average age was between 47 and 63, so younger than a lot of our other cancers, and most studies involved grade 1 to grade 3, typical and atypical neuroendocrine tumours. 26% of studies involve neuroendocrine carcinomas, which is the more aggressive and less friendly of already an unfriendly bunch of cancers. Speaking of the drug regimen and administration, just because it's a little bit weird, we don't use it that often, capecitabine is the standard capecitabine. You give it twice a day, day 1 to 14, and you'll have a week off. And the temozolomide was given for day 10 to day 14. Michael, do you know why, I think just from an education perspective, temozolomide, why they don't give it more?
I do not, Josh. Please tell me.
You do know. You're just humouring my silly question. It's because it's so myelosuppressive.
I do know that a big thing with temozolomide is not just any garden variety myelosuppression, but particularly lymphopenia. So if you have patients, and this is in the GBM cohort, but if you have patients on temozolomide, you do need to be very careful of not just bacterial infections, but viral infections as well. Josh is nodding. I have Josh's nod of approval.
Moving on. Thank you, Michael, for saying how much you like my nod. The primary endpoints, when we looked at the efficacy, what they found, this is the outcome, everyone. The efficacy showed a disease control rate of 77%, a stable disease in 40%, partial response in 34%, complete response in 2%, and progressive disease in 18.5% of the patients. The secondary endpoints, this is the culmination of everything. The median progression-free survival was only reported in 35 studies, and it ranged from 4 to 38.5 months. And the median overall survival was in 32 studies, and that was from 8 to 103 months.
And you were giving me grief about a wide reference range before, Josh. That's a huge range.
I prefer the term cheek. 8 studies, the median overall survival was not reached. The duration of treatment, which I went to look because that wasn't really reported, in the Sides 2016 article with pancreatic neuroendocrine tumours, grade 1 to 3, it had about 9 cycles as a rule, and the Lamarca 2017 study had about 6 cycles. But that's kind of extracting 2 and just having a discussion.
So to really pin down these results, because they are quite difficult to interpret, I suspect that the best takeaway from this would be to re-emphasize that neuroendocrine tumours, and this included neuroendocrine carcinomas, as you said, are a incredibly heterogeneous group of diseases with very variable outcomes.
That's exactly it. So that's really the summary, isn't it, Michael? It's heterogeneous, and there's not a lot of good data out there, and all the data that we do have kind of doesn't infer the same outcomes, which is probably because these aren't high volume sites. You get 30 patients or you get 47 patients. I'm looking at the number of patients in these studies: 30, 25, 28, 30, 65, 153, very, very small studies. Even the reference range was small as well. So that's something to kind of talk about, the number of cycles. And if we look at the safety was analysed in a bit over 1,000 patients. 13 studies had no data reported. 16.4% of the population had grade 3 to grade 4 toxicity, with hematological being the predominant one at 27.2%. Gastrointestinal at 8.3%, cutaneous at 3.2% with hand-foot syndrome, and others, there was a smattering of insomnia, anorexia, asthenia, and mucositis. So moving to the discussion, there was toxicity. They've said that surgical resection is the gold standard. Of interest, a recent phase 2 trial, which is a prospective phase 2 trial, including unresectable and metastatic gastroenteropancreatic neuroendocrine tumours, grade 3, which for them had a Ki-67 of greater than 20% and less than 55%. That was treated with CAPTEM, showed significant progression-free survival and overall survival improvement in NETs compared to NECs, being neuroendocrine carcinomas. And that reference difference was 9.3 months versus 3.5 months versus not reached versus the 6.2 months when we talk about progression-free survival in the first one of 9.3 versus 3.5, and overall survival in the not reached versus 6.2 months, favouring neuroendocrine tumours. Noted that neuroendocrine tumours had a lower objective response rate of 15.4% versus 34.8%. Wasn't statistically significant, and I haven't gone into finer detail, but I suspect it's probably a small number with this trial, and the disease control rate was lower in the neuroendocrine carcinomas as well than the neuroendocrine tumours. So it was 42.9% versus 98% in the neuroendocrine tumours, Michael. So you can see there the response to this treatment regimen very much is favouring that grade 1 to grade 3 neuroendocrine tumour cohort.
Yeah, so CAPTEM is definitely an option when you've got a high-grade neuroendocrine tumour, or even in the lower grade setting, which was included in this meta-analysis after you've gone through all of the stuff we've talked about in previous episodes, lanreotide, everolimus, PRT, sunitinib. But if you've got a neuroendocrine carcinoma, and this sort of emphasises the importance of continual monitoring and, looking for increasing FDG avidity on a FDG PET scan, increasing rate of discordant disease, that it might not be something that you want to necessarily use for a neuroendocrine carcinoma.
That's exactly it. And the only other interesting trial, which is another randomized phase 2 trial called the E2211, which compared CAPTEM versus temozolomide monotherapy in 144 patients with low or intermediate grade pancreatic neuroendocrine tumours. What they found is that there was no difference in objective response rate. So 33.3% for CAPTEM versus 27.8% for temozolomide, not statistically significant, but there was a statistically significant longer progression-free survival favouring CAPTEM of 22.7 months versus 14.4 months. There was imbalance in this arm as one of the patients included in the CAPTEM arm had pancreatic neuroendocrine tumour of significantly lower grade, which could justify the similarity in the objective response rates and a propensity score. So there were some flaws, I guess, in this particular study. But again, in saying that, there was benefit in the CAPTEM, and it's not a phase 3 trial either way, which is what we would like, but I don't know if you're ever going to get one with such a small, rare group of diseases.
I would very much agree with that, Josh. So a big part of how you approach treatment of these lower grade neuroendocrine tumours, and particularly with this rare grade 3, well-differentiated NETs, is going to be down to personal and institutional experience. I don't really think there's any good evidence that Josh and I have found that could help with sequencing. So it's really looking at the patient, speaking with your MDTs, canvassing opinion from specialist sites, hospitals that are more familiar with treating neuroendocrine tumours in higher volumes, and really just sort of making the best of the available evidence, because I don't think there's going to be a clear article or a subject-defining seminal trial on these tumours because they're just too rare.
Yes, just too rare, Mike. But speaking of rare, like quality podcasts like ours, what's our next episode going to be?
Well, we've sort of beaten around the bush this episode, mentioning the neuroendocrine carcinoma entity quite a bit. These are basically, Josh, they're small cell without the small cell. They're very aggressive, very nasty, again, very rare, but treated in much the same way. So not to spoil things too much, but we will be looking at platinum-based chemotherapy, which is much more effective in the carcinoma space than the neuroendocrine tumour space. And we'll also be looking at the inexorable intrusion of immunotherapy, try saying that 5 times fast, into this space with the amazingly named spartalizumab. So expect many references to the film 300.
And because I'm such a nice guy, I'm going to let Michael talk about spartalizumab. Is that the name?
Yes. I'll be saying this is spartalizumab an awful lot.
And getting t-shirts, matching t-shirts.
Yes, exactly. So if you want to listen to more rambling about spartalizumab or really anything related to oncology, we hope that you will join us next week and maybe go back and listen to our previous episodes. They're all just as messy, but no less informative for it. We'll see you next week.
Bye, Michael.
Thank you for listening to Oncology for the Inquisitive Mind. You'll find previous episodes on our website, along with weekly posts, resources, and links to our Twitter and LinkedIn pages. Check it out at inquisitiveonc.com. That's inquisitiveonc.com.